Everybody. So this morning I have the pleasure of announcing Petey's hematologist, and I'm really excited that she was able to make it. She came from Philadelphia, and so now I feel like more than half of the people in this room are from Philadelphia now, which we're just really happy to have her. So I am going to read her bio to you. Dr. Lambert is a pediatric hematologist with clinical and research interests in the inherited and acquired platelet disorders, that's us, and has been working with patients with genetic platelet disorders for the past 19 years. That's not possible. Right? Including those caused by chromosomal deletion syndromes, such as 11q deletion and 22q11.2 DS. She is the medical director of the Special Coagulation Laboratory at the Children's Hospital of Philadelphia and a co-director of the Frontier Program in Immune Dysregulation, a multidisciplinary program dedicated to diagnosing and managing patients with complex disorders affecting multiple organs due to immune dysregulation. She completed her undergraduate degree at Rensselaer Polytech Institute and her medical degree at UMBNJ New Jersey Medical School, now Rutgers. She completed her residency and achieved year at St. Christopher's Hospital for Children and her pediatric hematology oncology fellowship at the Children's Hospital of Philadelphia. Dr. Lambert completed a master's in translational research from the University of Pennsylvania after her fellowship. And since then, her research has focused on the mechanisms of autoregulation of megakaryopoiesis and molecular diagnosis of inherited platelet disorders. She has also helped to establish the Pediatric ITP Consortium of North America, a large collaborative group studying therapies and impact of ITP in pediatric patients, and is the recent past chair of the Operations Committee. She is a co-chair of the multinational effort of ClinGen to characterize pathogenicity of variants in genes in platelet disorders, and a previous co-chair of the ISTH Scientific Subcommittee on Genomics of Thrombosis and Hemostasis. Wow. And she was able to make time to come here. So thank you so much. We really appreciate it. This microphone?
Yeah.
Like this one. Got it.
Cool. Yeah.
I just don't want there to be feedback.
It's not getting feedback.
You can use it. Okay. All right. So I'm very happy to be here and to see some very familiar faces. Thanks so much for inviting me to come and talk to you guys about the bleeding issues in 11q and about the Paris-Trousseau syndrome. And I am going to try to keep my remarks brief because I want to give you guys time to ask questions, because really that's what I came down here for, so that you guys can ask me questions about your patient or your kids and or yourselves, and about any bleeding problems or issues that you guys have. So just to set the stage and put everybody on the same level, make sure we're all starting at the same place. I'm just going to talk a little bit about the different blood cells and what they do, and then about the platelets in particular, because those are the cells that are affected with Paris-Trousseau syndrome. So the red blood cells are, ooh, cool, jet, that's awesome. So the red blood cells are the part of your blood that make your blood red. They carry oxygen to all the tissues, and they are generally not affected in 11q, although if you have enough bleeding, you could become anemic because you could get to be iron deficient or something like that. And I've certainly seen kids who've had enough bleeding that they've gotten to be iron deficient. The white blood cells are the cells that help fight infection. We have two types of white blood cells. We have lymphocytes and neutrophils. And it's really the lymphocytes that help to fight viral infections that can sometimes get into trouble in 11q. But and they also help promote wound healing. So I'm not an immunologist, so I'm not really going to focus on the immune defects that we can see. But I think many of you have seen that children with 11q minus can certainly have problems with infections. And then the platelets are these tiny little, you can see these little blue things in the picture. They're the part of the blood that helps to stop bleeding when bleeding starts. And they used to be thought of as blood dust and be kind of disregarded as being unimportant. They help to stop bleeding. They also help wound healing and help to fight infections. So when they're not working, you can actually have problems with wound healing and with infection. And so the fact that your platelets don't work well in 11q can be contributing to the fact that you have increased risk of infection and also increased risk of bleeding. So when you have an injury to your blood vessel, the first thing that happens is those platelets attach along that blood vessel wall, and they kind of form a little barrier along that wall and stop the blood cells from escaping out the hole that just happened in that blood vessel. And we can actually watch that happen in real time now with the kinds of techniques that we have in the lab. And here we have an experimental mouse that had an injury to this blood vessel here. And you can see two little red blood cells escaping outside the blood vessel here, and a whole lot of platelets plugging up the hole. And that's it. Two red blood cells get out, and that's all. And the rest of the platelets just plug this hole, and then they form a nice little clot on top of that hole in the blood vessel. And eventually, if we let this run for long enough, actually this big old blood clot that forms flattens out, and then just that blood vessel will heal underneath there, and that clot will go away. All right, so the platelets, the small round cell, they're really very small, responsible for blood clotting and fighting infection and wound healing. And we see differences in the platelets in 11q that can cause problems with bleeding, wound healing, and fighting infection. Okay, so to understand the problems that we see with the platelets, we have to back up a little bit and talk about DNA. So DNA is the blueprint for all of our cells, and every cell has the same DNA, but what determines what that cell is going to act like are different transcription factors, different proteins within that cell that tell that cell, you're going to be a red blood cell, you're going to be a platelet, you're going to be a white blood cell, you're going to be a lung cell, you're going to be a heart cell. So the genes within that DNA are turned on and off by different transcription factors. And these transcription factors work as teams, usually, actually, to turn on the different parts of the genes in order to tell the cells what to do and tell them how to act. So this is chromosome 11, and this is the end of chromosome 11. And on the end of chromosome 11, there are two important transcription factors, X1 and Fly1. And when we delete the end of chromosome 11, here at 11q, we lose Fly1 and X1. And Fly1 is a very important transcription factor for platelets. And if you are missing Fly1, then the platelets don't know how to behave correctly. And most importantly, they don't form the little chocolate chips that are inside platelets properly. And so if we delete the end of the 11q, if we delete the end of that chromosome, we lose that gene. And we figured this out from studying patients also who have just changes in the gene Fly1 itself, because those patients have the same platelet defect without a lot of the other features that we see in patients who have 11q. So what we see in Paris-Trousseau syndrome is platelets that change in size and shape. And instead of looking like a chocolate chip cookie and having these little dark spots inside them that are sort of distributed throughout the platelet and looking like a really nice chocolate chip cookie, somebody stuck all the chocolate chips in the middle of the cookie and they're all clumped together. And that's what a Paris-Trousseau platelet looks like. And that's what Fly1 does. It tells the platelet to distribute those chips throughout the platelet. And when they're not distributed, the platelet, when it releases its contents, it releases everything at once instead of a little bit at a time. And so the platelet doesn't work as well. Does that all make sense?
Yeah.
Okay, cool. So what we end up with is platelets that are really variable in size and really variable in how well they work. And this defect, and this defect in the platelets is highly penetrant, meaning that most patients who are missing that Fly1 gene, like 85 to 90% of patients who are missing that gene, so depending on the size of the deletion, but if you're missing that gene, you have the Paris-Trousseau defect in your platelets. So you're at risk for bleeding. But the amount of bleeding that you have is highly variable. So you may have very minor bleeding symptoms, or you may have pretty severe bleeding symptoms, depending on exactly what happens. And when we see the type of bleeding that we tend to see is mucosal bleeding, and especially with surgical procedures that affect the mucosa. So if you get your wisdom teeth pulled, that's a high risk procedure. If you have a nasal procedure like a septostomy or a palate repair or something like that, that's a high risk procedure. But a cardiac surgery, for example, might not be a very high risk procedure because, first of all, those procedures almost always get platelets anyway. And second of all, it's not a big mucosal surface. And most of the bleeding that happens is within the vasculature anyway, because you're opening up the heart and stuff like that. And so if you're going to bleed, you're going to bleed right back into the heart. And so many patients will tolerate that cardiac surgeries just fine. And the risk of bleeding is out of proportion to the platelet count. So they may have a low platelet count. It might be 80, 90,000. And normally patients who have a platelet count of 80 or 90 or 100,000 don't have a lot of bleeding symptoms. But when your platelets are not working quite right, those chocolate chips are all clumped together, then your bleeding tends to be out of proportion to that platelet count because the platelets also don't work quite right. So normally a platelet count of 90,000, who cares? I mean, we care. I don't want to say we don't care, but like I'm not too worried about that normally. But a platelet count of 90,000 and they don't work right, I'm a lot more worried about that, especially if you say, oh, I'm getting teeth pulled. Oh, I'm getting surgery in my nose or my mouth, or I'm getting a biopsy in the gut or something like that. Okay, so let's talk about common bleeding. So common bleeding, nosebleeds and easy bruising. And these are common childhood bleeding. And we see this all the time in kids with and without 11q. And, but if you have platelets that aren't super effective, nosebleeds can get to be a lot more of a problem because it's mucosal bleeding. And so the nosebleed that is like not a huge deal at all, and somebody who doesn't have a platelet problem becomes a much bigger problem in somebody whose platelets don't work quite right because it just takes longer to stop that bleeding. And these are exacerbated by dry air or the heat coming on. If you have nasal allergies and the nose is all irritated, that will make it worse. And also is irritated by irritating or scratching the nose. And so the nice way of putting it is digital manipulation, or, you know, picking your nose. You know, and that's pretty common up until 6, 7, 8, 9, 10, 12 years of age. It really depends. And for some patients, it can even be up until 16 or 17 years of age. So it's really not unusual for people to do that. So it most often happens in the front of the nose because there's this very small, well, actually, it's a pretty large complex of very small blood vessels that come together in the front of the nose. So most nosebleeds happen in the front of the nose. This is good because we can see it, but it's bad because we can see it, and it kind of freaks people out. But it's a lot better than if the nosebleed is in the back of the nose, because then you can't really reach it to do something about it. It can be scary and it can look like a lot of blood. And then if you have a child then who starts crying and gets really upset about it, then that can make the bleeding even worse, because now you're basically pouring water over a spot that's bleeding. And I don't know if you've ever gone swimming after you cut your finger or a toe or something like that, then it bleeds even longer because you're now pouring water over a spot. It helps keep it open. And so the best thing to do when you get a nosebleed is to keep calm and not start crying, which is maybe not so easy to do with some young children. Pinch the front of the nose, the soft part of the nose, not the top or the hard part, and lean forward. And that may not be easy to do because then they're like, I can't breathe, but it's really important to pinch and hold the front of the nose and hold it for 2 full minutes. Put on a timer and don't let go for 2 full minutes. You can put a tissue around it or not put a tissue around it, but don't put a tissue up the nose, because then when you pull the tissue out of the nose, you're going to pull the blood clot out with the tissue, and then it's going to start bleeding again. So putting things up the nose usually just makes it worse. And so hold it for 2 minutes, and that's usually what we recommend as far as like hematology goes. If after 5 minutes the nose is still bleeding, we usually recommend sticking a little bit of Afrin up the nose, either nostril, the nose, the side that's bleeding or not bleeding. And what Afrin does is it constricts the blood vessels and basically helps the platelets to close up the hole by making the blood vessels smaller. And then again, hold pressure for a full 2 minutes and lean forward. And then if you're still bleeding after 10 minutes or so, call a medical professional. There are additional tricks that we can use and sometimes guide you with over the phone. There's some over-the-counter topical things that you can buy. Sometimes they're not always easy to find. But for the most part, those are our tricks that we use from the hematology side to help with nosebleeds. And usually they're really effective. But the most important thing is really pitch the front of the nose and don't let go and don't stick anything up there. So what about more severe bleeding? Certainly more severe bleeding has been reported, especially in 11Q minus. There are a couple case series of patients with bleeding in the head, in the brain. And the largest case series is 6 patients with a very variable age of onset of that bleeding, from 4 months of age, a very small baby with congenital heart disease who was getting a blood thinner. And it was around the time of their cardiac surgery, to most of the other patients in this series actually were in their 20s, in the setting of strokes and an aneurysm. There was only one truly spontaneous bleed that was reported in that case series, and that patient actually had really high blood pressure. And so I think that was probably the risk factor for that patient. And so I think that it is a bleeding disorder, but not one of the ones that we think about when we think about spontaneously bleeding in your head. But in general, we do recommend avoiding medications that can interfere with platelet function or that can increase the risk of bleeding, unless there's a really strong reason that you need to be on those medications. And some patients with 22q have congenital heart disease and need to be on aspirin or some other antiplatelet medication. So that risk benefit really needs to be very carefully balanced. It's important, if you're going to be on those kinds of medications, to really carefully monitor for things like high blood pressure, and monitor other potential risks for bleeding in your head. and to strongly consider whether or not oral contraceptive, whether estrogen is the right oral contraceptive to be used, or whether one of the other non-estrogen containing regulators of menstruation is a better option. And then really trying to avoid head trauma, which is, you know, when you're 2, maybe totally impossible, but those little head bumps are less of a worry, but like maybe not doing things that put you at high risk, like playing football, boxing, ice hockey, those sorts of things, and avoiding the kinds of activities where part of the object of the game is to hurt the other person as much as it is to play the game. And then having severe infection or being in an intensive care unit is also a risk factor for having an intracranial hemorrhage, whether or not you have 11Q minus. So trying to avoid that if you can, which, you know, is sort of said tongue in cheek because nobody plans to be in the ICU. So warning signs of an intracranial hemorrhage are severe headache, especially sudden onset, or if you have nausea and vomiting that kind of come out of nowhere, especially when it's with a headache or after a head trauma. So those kinds of symptoms are symptoms that really should be evaluated by a medical professional, particularly if they're going on for a period of time and they're really just not getting better. So my recommendations to patients are to assume that there's platelet dysfunction for the majority of patients, even once their counts have normalized, if they had a low platelet, especially if they had a low platelet count in infancy, and for mucosal surgeries, especially to act on that assumption and to plan surgeries considering a platelet defect. To evaluate platelets using electron microscopy and platelet function testing whenever possible, although recognizing that not everybody lives close enough to a platelet specialty care center where you can get that kind of platelet evaluation. And so it's safer to assume the platelets don't work well and to avoid the kinds of medications that might make the platelets not work well even more, and to plan for surgeries. And those were the things that I wanted to make sure that I sort of talked about to set the stage. And with that, I'm happy to answer any questions you guys have. Sure. Sorry to catch you napping, Pete.
Recently, for just normal blood tests and a physical, her annual physical every year, she's coming up with dangerously low iron count.
Mm-hmm.
And we don't have a hematologist. We live in Denver. We did years ago, pediatric. So we actually just had a meeting with the kidney doctor, routine, and he said, you need to go to a new hematologist to figure out why this keeps happening. So she's on iron supplements, mm-hmm. But he explained it as once you go off the supplements, if it still drops dangerously low again, then you either need an iron infusion, mm-hmm. or a scope to find out if there's some type of internal bleeding that you have no idea about, which is causing then the iron deficiency, which is then causing anemia, mm-hmm. From the red blood cells.
Yeah. So iron deficiency it's a diagnosis, but it's really just a symptom, because most of the time we get enough iron in our diet. It's really, except for in toddlers where milk can interfere with absorbing enough iron. If you can actually drink enough milk to interfere with absorbing enough iron and become iron deficient. Once you pass that sort of time period in your lifetime and you get to be older, it is hard to become iron deficient from diet alone. And so that means you must be losing iron somewhere. The most common cause in women and menstruating females is menstrual bleeding. But if you don't have heavy menstrual bleeding and you have a normal diet, then you must be losing blood somewhere else. if you keep becoming iron deficient, once we fix the iron deficiency. You have to have a leaky bucket. If you refill the bucket and you somehow lose the iron again, because the body really only needs a small amount of iron every day in order to maintain that iron level. And so that usually means you're losing iron in your gut. That's the most common place to lose iron. And so I would agree that probably needs a scope if still losing iron, assuming that she's not having heavy menstrual bleeding.
Well, she has, in my opinion, regular menstrual bleeding.
Yeah.
But she also, when she has her period, has had vagal
Episodes,
vagal
syncope, yeah.
always, every other time
Mhm.
on the first day of her period.
Mhm.
And it looks just like a stroke
Oh,
when it happens. But we've already figured out what to look for, and
Yeah.
I've been with her every time it's happened. But I think it looks fairly normal, but maybe for her body size, she's having a heavier period, because that's the first thing they said. So do I go to a new hematologist and describe all this?
I would probably see a hematologist, describe all of that, and then it's not unusual for menstruating females to become a little iron deficient just from menstruating. So maybe just, nowadays, girls don't have to get their periods. We know it's very safe for that to be the case and for us to suppress menstrual bleeding and to basically, take that out of the picture. So if she doesn't become iron deficient, if you take periods out of the picture for 6 months, then it's just from her menstrual bleeding.
So does the iron go up and down based on the menstrual period?
Mhm.
So if I were to get her blood looked at every other month and or just stay on supplements?
Yeah, a lot of times what we do is iron while you're menstruating and then not in between. Because the reason that we need very little iron is we hold on to it very well and so, in general. And so the downside of taking iron every day if you don't need it is that you can actually get to have too much iron, which can cause problems too. So you have to be a little bit careful with iron. It's not good to take too much iron, but on the other hand, taking iron, for example, while you're bleeding is reasonably safe. And a lot of the new oral contraceptive pill formulations actually contain iron in them, like Junel FE, low estrogen FE, all of the birth control pills that say FE at the end, they all contain iron, and the placebo week has iron in it, basically. And you just take the iron during the placebo week.
Thank you.
Mhm.
Hello.
Our daughter Charlotte is 10 years old, and even though she doesn't have severe bleeding problems when she cuts herself or something like that, she has severe problems with bruises, and she gets nosebleeds up to 3 to 4 hours until it stops, and she sometimes has bleeding ears as well. And our hematologist actually gave us a kind of emergency package with tranexamic acid to treat that if it absolutely doesn't stop. What are your thoughts on kind of these kinds of emergency packages?
Yeah, I love tranexamic acid, actually. I use it all the time for patients who get nosebleeds that last a long time. It is, yes, it's actually usually better tolerated than Amicar, although it doesn't have a great liquid formulation. So you have to crush the pills, even though it says on the package, do not crush the
We
pills.
actually get the injection.
Oh, yeah, or you can take the injection and just drink the injectable form. But tranexamic acid, TRANEXAMIC acid. The trade name is Listetta in the United States.
What is the trade?
Listetta, LYSTEDA.
Anybody else? Back here.
Yeah, so Stymate was recalled And so intranasal DDAVP used to be a really nice option also, but unfortunately that was recalled and currently is not available because the concentration over time was increasing. And so it was basically not stable in the formulation that it was. And they haven't yet figured out how to fix that problem. They're working on a new intranasal formulation, but the problem is it's really only going to be stable for about a month at a time. So you'll have to get a new DDAVP prescription every month. And that's going to be super expensive. So for patients who use it a little more regularly, that might be worthwhile. But for those patients who are using it as part of an emergency kit or something like that, it really isn't, it's probably not going to be worthwhile to have that at home.
I was wondering, are there other signs of internal bleeding apart from the headaches and the nausea? Because some of our kids do not really complain very often, or they are not able to express what they feel. So.
Yeah. So bleeding. So bleeding in the head is tough. The other types of signs that I would look for is changes in behavior, irritability, or like new irritability or new sleepiness, or other changes in behavior. I want to stress that bleeding in the head is incredibly rare, and incredibly rare. And the only reason that I brought it up at all, I don't want to scare anybody or anything like that. I just want people to be aware and to consider before using, I think in particular, over-the-counter medications that can interfere with platelet function, like ibuprofen and Aleve, like NSAIDs, like naproxen or Aleve, or aspirin, or things like that, or cold medicines that can contain those medications. Because sometimes what happens is patients will get into a habit of using those on a fairly regular basis because they have because somebody complains of a tummy ache. Oh, I'll give a little bit of Motrin. Oh, they complain a little bit of a headache. I'll give a little bit of Motrin, because it feels like it's a super safe thing to do because it's over the counter. And in general, it is a super safe thing to do, but doing it every day when your platelets don't work makes it a little less safe. And so I think trying to find other ways to go around that little bit of a tummy ache, a little bit of a headache, a little bit of leg pain at the end of the day, rather than using the ibuprofen or even the Tylenol or whatever, it is really kind of what I'm just trying to bring up. And then I think over there and over there.
Is Tylenol also not safe?
No, Tylenol is okay for like fevers, or Tylenol is okay, it doesn't interfere with platelets. And there actually is an NSAID that doesn't interfere with platelet function. It's called Celebrex or Celecoxib. Doesn't interfere with platelet function. So, but it's prescription only. So if you, for example, get, fall and get a knee injury, like sprain your ankle or something like that, and you need an NSAID for the anti-inflammatory effect, there is, but it's prescription only. So it's called Celecoxib or Celebrex.
Piggyback on medications that we shouldn't have. Some of the old guard here, we're familiar with the ones we shouldn't have, but for some of the benefit of the new families, would you be able to list medications that we should always avoid when you have platelets that don't function?
So I would avoid any of the medications that have antiplatelet effects. So NSAIDs or aspirin. And I would avoid coagulants unless you have a specific indication to be on them. And I would definitely discuss with your doctor the risk benefit of being on an anticoagulant. And if your doctor is putting you on the anticoagulant just sort of because it's routine without thinking about it, I think it's important to say, well, wait, let's just stop and think about it for a minute before we just decide to do it for my child, because my child is not every person who comes into the hospital. And some of the other medicines that can interfere with platelet function, there are dietary supplements. So like high doses of garlic, high dose turmeric, those sorts of things can also interfere with platelet function. And I know that a lot of people now use those kinds of natural remedies as well. So normal garlic in your diet is fine. Even an Italian diet is fine. I'm talking about taking garlic pills. Fish oil can interfere with platelet function. So yeah, so turmeric has been shown to, in some clinical studies to interfere with platelet function. If you've been on it and it's been okay and you haven't noticed a change in bruising or anything like that, then I think, then it might be okay. But oh, turmeric in the diet is fine. Again, I'm talking about like pharmaceutical dosing of turmeric, right? Like pills of turmeric that you can get at like GNC and stuff. Vitamin D is fine.
But one more question on that. Pete, we were looking at putting him on a medication for like ADHD type symptoms. And when I told the doctor about the platelet disorder, he said, I forgot which medication.
Oh.
It can make them slippery.
Oh yeah, so some antidepressants like SSRIs
Yes.
Can also interfere with platelet function. So the SSRIs can also interfere with platelet function. Those are tricky also, like anticoagulants, because there may be a very good reason that you need to be on an SSRI, right? And so what I usually recommend for families in that setting also is start low and go slow. So start at a low dose and really monitor symptoms and go up on the dosing slowly. So sometimes patients can tolerate it just fine. But if you notice an increase in bleeding symptoms, then you have to back off on the dose and you can't go up any further.
That's the same as some of the seizure medications.
Yeah, some of the seizure medicine.
Like, if we're gonna start this, we're starting at the hospital.
Yeah.
Like checking his blood every day.
Yeah, and well, so some seizure medications can drop platelet counts in particular, and so those medications are the ones that people would worry about, I think, in that setting.
I can talk loud. So she said my daughter's had 2 failed platelet function tests done. Do you recommend we keep trying, or do we just assume that they don't function well and follow everything you're recommending, or would you say like just keep trying?
Failed because they couldn't get enough blood, or
She's at go to Chapel Hill and they've taken her blood twice and both of them just were not that like
yeah.
Yeah. So I don't know, like if it's been a year now.
Yeah.
Try again, you would say get a blood drawn again and
I mean, so if they're having trouble getting platelet function testing on her, it might be easier to just do electron microscopy. But the truth is that if her deletion involves the FLY1 gene, her platelets probably don't work normally, even if her platelet function testing is normal. And because, again, it's the problem with the granule disorders is when we do platelet function testing, we're basically hitting platelets with a sledgehammer and saying, can you react to a sledgehammer? And so you have to have pretty significant platelet dysfunction to be like, oh yeah, I can't deal with that. So certainly there are patients with Paris-Trousseau anomaly who do not respond normally on platelet function testing. But there are more patients who have abnormal electron microscopy. In other words, their platelets are abnormal when we look at them. The chocolate chips are all at the center of the platelets. And those patients are at risk for bleeding with certain surgical procedures and have worse nosebleeds and easy bruising, but they test perfectly normally on platelet function testing, because again, we're hitting the platelets with a sledgehammer and not hitting them with like just a tiny little tuning fork and saying, can you still react normally if I just hit you lightly? And so it's all about how sensitive are the platelets to, and how normally do they react? And so I think the best test is probably platelet electron microscopy. And that's a lot easier to get, actually. Oh boy.
I wanted to touch base back on your, the oral
Yeah,
dental
yeah,
procedures and stuff like that. We had an incident where we were tracking the platelet counts due to excessive bruising,
yeah.
and it was like 89.
Mhm.
Our practice is that if we have a count, 80s, we would assume she's more in the 40s, like some ain't gonna work. And then that's how we let her do her physical activities based on stuff like that. When she's in the 50s, then we assume 20 somethings. We kind of limit little things and kind of modify stuff. But we had platelet counts of 89, did not get an infusion because we were going to do superficial fillings and stuff. But it seemed like at the event, I can let Melissa, a caregiver, kind of give a quick description of the scenario that it was like touching the gum, was just setting everything off. So most of the dental, appointment was handling bleeding control.
Mhm.
And so over time, if we have an account like that, it's extra deceiving for us because we weren't prepared or expected that. Would you recommend, regardless, we just do infusions? Because now we're to the point where, she's getting allergic reactions sometimes during infusions. So I'm like, where do you find that fine line?
Yeah, so for dental procedures, I think a lot of times what I recommend is tranexamic acid starting the night before, and DDAVP plus or minus platelet transfusion. So often platelet transfusions, if they're just doing superficial stuff, are not needed, but tranexamic acid rinses. So get the liquid tranexamic acid, get the IV formulation of tranexamic acid, and rinse the mouth with tranexamic acid before the procedure.
Do we include that dosage at night still?
Yeah.
Or we do it for a couple of days after?
Yes.
Because it's then kind of boosting acid.
Yes. Yeah. And because it's basically topical tranexamic acid, because there's a lot of antifibrinolytic in saliva. Or fibrinolytics in saliva. So your saliva basically breaks down blood clots. So if you put the tranexamic acid directly in with the saliva, you counter the effect of the saliva on the blood clots.
Is that something that you would consider we include into protocols?
Yeah, that is something that I put in my dental protocols, is to do either liquid Amicar or liquid tranexamic acid. And if I can't get the liquid tranexamic acid, I'll crush the pills and make it into a slurry, which my pharmacists hate. They yell at me for it all the time. They say it's not recommended that you do that. And I say, okay, fine, but it works. So.
Hi, I really appreciate the explanation you gave to your question. For my daughter, we just got back all of her platelet function results, and they seem to be fairly normal, and your explanation is great for providing context. We haven't got the electron microscopy done yet. So when I sat down with the hematologist and I provided to her the recommended bleeding protocol, and I also given that to the pediatrician, the hematologist said, well, we did her function test. She does not have Paris-Trousseau syndrome, so don't worry about it at all. I said, okay, well, if we're going forward with like maybe a dental something, is this, or we end up in the emergency room, is this something I should present to them? And she's like, nope, don't worry about it. It's done. So my question is, as a layperson, I appreciate you're the expert and you provide providing us with some guidance here, but when you approach another healthcare professional, it's hard for me to say, well, according to Dr. Google or according to whatever, right? Like, this is what I recommend. How do we approach these situations?
What I might ask is, well, how good are platelet eggs at detecting a granule defect?
Just haven't talked.
And if that doesn't work, can just say, well, can you give Dr. Lambert in Philadelphia a call? I'm happy to talk with him.
Could I just ask on that same remark, do you happen to know the distance of the missing fly1 gene from the terminal of 11q? Because I know some people here have different megaphase deletions.
Probably about 7 mega.
Okay, so like if someone had maybe a more minor deletion, it may not impact their child.
Correct.
Okay, thank you.
That was why I made the talk itself. That's why I made the talk itself fairly brief.
So we actually see another doctor in child. I can't remember her name right now. But when she was diagnosed with Paris-Trousseau and Von Willebrand. What's the difference? Like, can you have both?
Yeah, so Paris-Trousseau is the platelet defect that we see associated with 11q, and that's the chocolate chips in the wrong place in the platelets. The von Willebrand's disease is a different bleeding disorder. It is very common, particularly in Caucasian populations. Actually, it's the most common bleeding disorder in the United States. And so it is certainly possible for somebody to have a rare bleeding disorder, Paris-Trousseau, and a common bleeding disorder, which would actually make the bleeding phenotype much worse for both, right? Like if you had 2 mild bleeding disorders, you would expect somebody to then have a more significant bleeding disorder and have more bleeding symptoms at baseline. And I think you could certainly envision that somebody could have both. The other thing, though, that is possible is that the von Willebrand testing could have been spuriously abnormal as a result of the Paris-Trousseau anomaly, depending on how they did the testing. And it depends on when they did the testing. If the testing that they did was ristocetin cofactor based, her von Willebrand factor activity was ristocetin cofactor based, she might have tested abnormal. And if they repeated her testing now with some of the newer technology that we use, she might test normal.
If I could just follow up on that, I've had patients tell me that their hematologist swore to them, to her point, that they had von Willebrand's disease and not Paris-Trousseau. I said, no, that's not true, for exactly the reason you said. So you guys are smarter than some of the hematologists. You have to stand up and really push that protocol in their face, because that is a medical legal document.
Is it there in Canada? Is that as well? Is that where you are?
Right?
In Germany.
I can't swear. I think it's probably case by case, but again, I mean, she graciously offered to be the go-to person, much more qualified than I am, obviously. So, refer them to the expert, and you just have to. You can't take no for an answer when it's something so clear.
I'll give Jessica my email and Lindsay my email, and you guys can just email me if you know.
Thank you.
I just wanted to share a quick story about my daughter had her wisdom teeth out, I think 5-6 years ago. It was near disastrous where I took Paul's bleeding protocol. I took everything in there to the pediatrician, and then the pediatrician called the oral surgeon, and he just kind of poo-pooed that. Then got permission from the insurance company that it had to be done in a hospital, had an amicable protocol, platelet transfusion, get a call the night before, and that particular hospital, the medical director said, nope, we're not going to do that here. Way too dangerous. then had to go to trauma. The first one was a trauma level 3, and then they took her to a trauma level 2, and she had the platelet infusion the night before, which was critical because they said it's got to be in her system for X amount of hours before the surgery the next morning, so it has to be given here. And then I go in when they take her into surgery, and the doctor hadn't given her Amicar yet, and it was on the order. And I looked at the nurse and I said, "Did she get her Amicar?" "Oh no, there's no Amicar on the order." And it was the Amicar, but the oral surgeon said, "I'm not a geneticist, I'm not a blah, 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 I just take the teeth out." And she was in the hospital for 4 days. And it was a major surgery, so it was coordinating 3 doctors and then trying to coordinate the hospital medical director to provide the right care for her.
Yeah, that just
I'm
happened
sorry.
3 weeks ago. A girl up in San Jose spent over a week in the ICU.
I'm sorry.
Yeah.
We have at CHOP, we have a protocol. So we actually usually just do the platelet transfusion 30 minutes before, have them come in that morning, do the platelet transfusion 30 minutes before, start the Amicar tranexamic acid the night before. Our dentists will do topical thrombin after they remove the wisdom teeth, and we'll make sure that they get pretty good bleeding control before they're done. They almost always will actually put in a stitch to help close the socket for wisdom tooth extractions for our bleeding disorder patients. And then the patients will stay for wisdom tooth extraction. So they'll get a platelet transfusion before, plus or minus DDAVP, and then they'll stay for a second dose of DDAVP and to continue tranexamic acid or Amicar. And then they'll go home the next day. So they'll stay overnight.
Thank you. Just a quick one. We've got one more medication that was recommended by our hepatologist, which is Novo 7.
Yeah.
It's like for the bleeding disorders, but that is only for severe surgeries or something like that, because not every hospital has it. And but my question is, could you provide us with like a written recommendation, what kind of blood testing should be done by a hematologist that is refusing to do what we say?
So I would recommend anyone with 11Q have platelet function testing and electron microscopy.
Could you write it down?
Sure.
Well, maybe it would be great if Dr. Lambert is willing to take a look at our protocol and make any updates.
Yeah.
Because it's over 10 years old and you're willing to do that.
Yeah, I can do that. I'm happy
would
to
be
do
awesome.
that. And then as far as the Nova 7 or recombinant 7A goes, we tend to use that only when we get into trouble with bleeding, because it also carries with it a very high risk of thrombosis, so and blood clotting. So we tend to reserve that for those patients who run into trouble and not use it prophylactically. But in some patients, you know, if we get a wisdom tooth extraction that goes badly, and or a septoplasty, you know, a nose surgery or a mouth surgery that goes badly, we do use it in those settings to try to get control. But you have to have functioning platelets for 7A to work. So you got to give platelets with 7A.
Could you give some recommendations for different types of medication for menstrual bleeding? So you mentioned that the estrogen ones.
Yeah, so I'm not a gynecologist, but I send all of my young women to our adolescent medicine department, but what our favorite right now actually is the progesterone coated intrauterine devices. coated intrauterine devices. So there are these teeny tiny little plastic progesterone coated devices that get inserted into the uterus and they stop menstrual bleeding. It's basically local release of progesterone to keep you from building up a uterine lining. And you basically get no menstrual bleeding for 5 to 7 years at a time. And then you'll get some breakthrough bleeding and they remove the device and they put the device back in again. They can be placed in you have to have had menarche, so you have to have started having a menstrual cycle, but anytime after the first menstrual cycle in virginal girls who have not had, who have never been pregnant or anything else like that. So you can place them in very young girls, and we've had those IUDs placed in girls as young as 10 and 11 years old. They'll place them under anesthesia in adolescent medicine.
We actually go to CHOP and Philadelphia. Personal question for you. We've been trying to get into you for. Tell them to take my opportunity. We have an pre-course. And the paper was canceled, due to COVID and everything. And now they're saying only returning patients can come back. So I wanted to know, can we just squeeze in with you?
Yeah.
I have calls, whatever you need.
Yeah.
This is a great example of advocating for your.
Yeah, I'll give you the email address to my new patient coordinator and you can just email her and we'll get you on the schedule. But full disclosure, I leave on Friday for the UK and then, so it's not going to be until August or a little bit later. Petey, where'd you go? You're slacking, man. Petey ducked out, man.
I wanted to touch base back on, advocating, because that was a wonderful example, but Dr. Grossfeld had specifically said about a patient in San Jose with the oral surgery complications. We had lived in San Jose and had to do a lot of advocating and researching in order to find an oral surgeon who had, doctor surgeries and was able to we're Kaiser patients. So he was able to get, surgical rights to do the procedure in the hospital. And it worked out well that he was listening and willing to work around the scope and parameters of, Jacobson's. And it worked. 12 teeth removal polyps included a lump of wisdom teeth being taken out. It was a pretty significant procedure for such a small jawline. And he took it to do it early enough to not make it as invasive later. So I'm going to push really hard for you guys to advocate and really do, work with oral surgeons and like that, because most kids have that really small jawline and have those growing teeth coming in, and it's going to be a big deal. But they did, really work well with the Amicar packing the throat to make sure a lot of bleeding wasn't swallowed and all that kind of stuff. There were complications afterwards, and we were like a step down from ICU, but we stayed there.
Yeah.
And even though the saliva and stuff swallowed out, like caused a lot of vomiting, we are really good advocate push for, for them to communicate with your hematologist and stuff so that you have better results like that and not end up like the patient that Dr. Russell was describing.
And I would say to your question earlier too, it is okay to also go back to your hematologist and say, I just got back from a 11Q meeting and they were talking about the importance of electron microscopy to diagnose the platelet defect in that meeting. Like, it's totally reasonable to bring back what you learn at this meeting to your hematologist and say, I'm trying to educate myself. Tell me what you think about this, because this is what I learned at this meeting. What do you think? And then if they still won't listen, number one, think about whether you need a new hematologist, and number two, feel free to tell them to call me. And if they still won't listen, feel free to call me and tell me the name of your hematologist, because I might know them, and I'm happy to call them.
What's that called again?
Electron microscopy.
Electron microscopy. Using
Yeah.
electron microscope.
Yeah, basically, that is exactly what we're doing.
That's what those pictures were at the time.
Yeah,
Okay.
I like that.
There you go.
I love chocolate chip cookies, honestly, my favorite cookie, 100%.
Hi.
Yeah.
Megan is due to get her wisdom teeth out along with a number of her first.
Not trying to scare you in any way.
And we tried to schedule it before COVID and it's been delayed, so
Sure.
we're here now. I think we're in pretty good shape, but you mentioned a few new things, and I'm wondering if that's something that you have, that protocol you have, that you can share with this group or with me personally?
I can ask my bleeding disorder nurses to give me a copy of it, sure.
That'd be great.
Yeah.
Yeah, that would be helpful for us. And also you were mentioning earlier, there's several medications that mess with the platelet function,
Mhm.
and I wasn't aware of that. Is there a list for that somewhere?
I mean, if you Google medicines that interfere with platelet function, that list is super long.
Yeah.
Okay. So, but like the SSRIs, so like Prozac and all of the medicines in that class of medicines, the NSAIDs, so ibuprofen, Motrin, Advil, and naproxen, naproxen, and aspirin. Those medicines, those are the big ones that are commonly used. If you look it up, they will, on the list of medicines, things like antihistamines come up on the list of medicines that can interfere with platelet function, but they don't really interfere with platelet function to a great degree unless you're taking super high doses of those medicines. And so, and in part, that's because platelets are kind of finicky. And so when we're doing evaluations of platelet function, if we ask people, what medicines did you take? And then we do some platelet function testing. If that platelet function testing then comes out a little bit wonky, indeterminate, then we might say, oh, it might have been that medication that you were taking that interfered with that. And then that ends up on the list of medicines that interfered with platelet function. And so I think that's why that list gets to be so long when you look up the list, like, on Google or Yahoo or whatever. But realistically speaking, the list is not as long. Some of the seizure medicines, because and the SSRIs, because serotonin is very important in platelets. And so serotonin reuptake inhibitors, that's the class of antidepressants that will interfere with platelet function, but not in everybody.
Antipsychotics as well?
So not typically.
Okay, thank you.
Mhm.
Dr. Lambert, do we need to take bleeding preventative protocols for just standard dental procedures or cleaning?
So I don't usually recommend it for a regular dental cleaning. Usually you don't have to do anything particular for those. If they're going to be pulling teeth, they need to know that she's at risk and they need to do something different. Even for baby teeth, because baby teeth are supposed to fall out and you're not supposed to have bleeding when baby teeth fall out. But if you're pulling a baby tooth out, something is different. And then you may end up with bleeding if they have to pull the baby tooth. And so you probably at least want either Amicar or tranexamic acid for pulling a baby tooth. And if they're pulling an adult tooth, then or a shark tooth or or an extra tooth or whatever, then you probably need something for that to keep it from bleeding.
Thank you.
Do you have a recommendation for a dentist
Yeah.
in the Philadelphia area?
Yeah. I can send you guys that.
Excuse me, will she send it to you?
Yeah, I got it.
We usually use Penn Dental like the family practice, because they will do their procedures at CHOP if you guys need to have a procedure. Cool. I'll be around through lunch, so you guys can ask more questions then too.
Thank you so much, Dr. Lambert. So I think we've all learned something new today, even the old guard, right? Am I right? So thank you so much. We really, really appreciate it.
Thank you.
Okay, so the next up is our 11Q adult panel, which is by far, I think, one of everyone's favorite sessions.